Equity Week is a national week of reflection on issues of equity in resource distribution in Kenya, and in 2017, this took place from the November 13th to the 17th. Several events were held in various venues in Nairobi and Elgeyo Marakwet County and brought together individuals from academia, the civil society, government, the arts community, development organizations, and citizens for a conversation about the promise of more equitable development as enshrined in Kenya's 2010 Constitution. There is a long history of unequal access to government services in Kenya, including access to basic social services such as education and health. Before devolution, some areas felt they were marginalized and they did not enjoy the same level of access to services and development as other areas in the country.
When we were campaigning for the new constitution, Kenyan people were promised a lot of things. And most of them knew that with the coming in of county governments, all their problems will be sorted once and for all. And it became really a challenge. And for Elgeyo Marakwet, during the second financial year, we realized now that it was a challenge. And that triggered the county assembly to come up with a bill, an Equitable Development Act.
Now, devolution and generally the whole concept of us changing the constitution, there was, I think, a credible belief that marginalization was a big issue in Kenya and we needed to change the way we distribute resources as a country. Even before devolution, there were a couple of things that we were trying out to try and improve the situation. So you had, little funds here and there, CDF being one of those, very celebrated by MPs. I don't know about you guys. But that still continues even after we changed the constitution, in that there is still a belief that as we are dealing with issues of marginalization, we'll create little funds here and there. So CDF has become very big. Counties have also started trying to create their own little CDFs with the word development funds. So there is still I believe that we need to think about the inequalities that exist within the country, but the approach that we take and the discussions that we are having, as Jason mentioned earlier, is slightly different from a broader discussion that covers a broader spectrum than just the little funds and the CDFs of this world. Now, while devolution is great and those funds have their own merits, the discussion about the bigger budget and how equitable the distribution of that bigger budget is has remained non-existent, in fact, in many of the conversations.
It is good to note that devolution has indeed had a positive impact on how we distribute national resources since 2013, when counties started operating. Services that were previously accessible only in certain areas or to certain classes of people have now been decentralized and made accessible to other people. When we make a comparison of the situation pre- and post-devolution in some counties, specific positive trends in the provision of healthcare services can be observed.
When we looked at research on the health workers, for example, we saw that there is some positive impact of devolution towards resolving the inequalities that were present prior to devolution. So we see that devolution, because spending of health sector is driven by counties, we see devolution as a positive thing in the country, because we can tell that things are changing for the better in the counties where the counties have control. But at the national level, it's still status quo. They are spending as they used to spend. So there could be implications for that, but what we could say is devolution indeed has had positive impact on equity in this country.
Let's look at the pre-devolution situation. Three things. At the time of devolution, there were certain inequalities, and we're going to look at three. We see that there was unequal spending. There was obviously an equal number of health workers. And when we look at the distribution of county residents per health workers was also unequal. And we also look at the skill mix at the beginning of devolution. Then now we look at post-devolution. We got from 7 counties, and what we see is an increase in health workers, a positive change in health workers, but it's not similar. So you see counties like Samburu, there's 13% increase in health workers, and counties like Turkana, for those 10 categories, 232 increase in health workers. So it's a significant increase. But the trick is just look at the numbers. Still, they don't have as many health workers as they would need for the county, okay? But there is positive change.
One of the things that devolution has done, I mean the most obvious, is the fact that management of health services in terms of implementation is at the county level. So that means that in one way we expect, and we have seen actually, that different counties have come up with different interventions. It has also, I think, in a big way helped to locate the need, in terms of where is it that we don't have enough doctors and nurses, where is it that we don't have dispensaries, and we have seen, cases like we covered during the Equity Week around employment of doctors and nurses. You find Turkana has employed, a huge number of doctors and nurses. West Pokot has built health units and dispensaries. So different actors. But the other thing that we also devolution has done is that it has also in a way raised the stake of healthcare provision, in the sense that when there is a problem, people know that they don't need to fight to go to Nairobi. They can just go to their county headquarters and things will be fixed.
Overall, when I look at healthcare before devolution and healthcare after devolution, when we look at it really closely, you realize that devolution has been such a good thing to health system in the country because of two things. One, infrastructure-wise, there are places where to get a dispensary, it would be so hard. But then post-devolution, we've had, also for political goodwill, these governors want to be re-elected. So they throw a dispensary here, upgrade a hospital there, for their own re-election, which is a good thing. Unfortunately, like someone raised it earlier, sometimes you don't think about the personnel. So whereas the infrastructure is being improved, the software, the soft skills are not being improved. The second thing that devolution has really helped us with, and it has spread it now to even areas like Kibera South. In a facility like that, you'd never find a medical doctor. But right now, we have medical doctors there.
According to Article 175 of the Constitution, one of the objectives of devolution is to ensure equitable sharing of national resources between the national government and all the 47 counties. The Commission on Revenue Allocation tries to achieve this through a number of mechanisms such as the equitable sharing formula that distributes revenue among counties and the marginalization policy used in the distribution of the Equalization Fund. However, large inequalities also exist within counties, and there are unique interventions being made by individual counties to address them.
When we talk about the development, we always talk about good governance, inclusivity, participation, and consultative approaches. But when you just ask yourself that with good governance, with good participation, without equity, will our people be satisfied that we are doing the right things? And we realize that however much we prudently utilize our resources, without that equity, our people could not understand and even appreciate the good practices that we are applying.
What is equitable? Do you just divide the resources to all the wards and you start implementing projects? What are the parameters that we need to consider before doing all these things? So there are so many perspectives, but as Elgeyo Marakwet, we tried a formula, and I think that formula is working.
Through this act, 60% of our development budget were shared equally among the 20 wards, and the remainder, the 40%, were shared based on population. Of the 40%, 38% were shared based on population. We also had county flagship projects, which we We gave them 23%, poverty index 22%, the land area 8%, emergencies, we took 5% of the 40% development to go to emergencies, and fiscal responsibility, and also bearing in mind the diversity of our county. We know we have areas which are semi-arid, and other areas are well off. They receive enough rainfall throughout the year. And I think through this formula, somehow the people of Elgeyo Marakwet are appreciating devolution. And we've been trying to see how we can improve on this act. Remember, it was done by the first county assembly, and as we continue working with our new county assembly, we are yet to have another sitting and just share the challenges, share the successes of this act, and see how we can further improve on it.
I've been to West Pokot. They've built a doctor's plaza, and they budgeted for that in 2015-16 and 2016-17. Same case to Samburu. They are trying to put staff houses in their county, and they're offering means of transport like their motorbikes to go to those areas that are hard to reach. And then for Elgeyo Marakwet as well, they're trying to put residential facilities for their health workers. And then within Samburu, they promoted staff just to encourage them to stay in their county. And then we're seeing that in counties like Elgeyo Marakwet, they're improving their working environment. So they're trying to attract and retain health workers through various strategies.
One of the good things that we did with devolution is that we decided we needed to have a more predictable approach to how we distribute resources across the country. And across the country in these terms came regions, which are counties, and so we have a formula that guides how much money goes to each county. Now, if you look at that formula, it has a couple of things in it. So we distribute those resources based on issues such as population, how poor the counties are. We do have an equal share that we give to each county. We have something on fiscal discipline, which we are still struggling to define. We've tried, but we are not yet there yet. But also we look at the vastness of the areas. So because if you're in a wide county, then probably you need more money to distribute or to get services to people. So that's basically what we use. And I think one of the things that has been good about that is that it's a formula that is designed in a way that it ensures that you're giving money to where there is need. And so the higher the population in a place, probably the more money you need as a government in that county to provide services. But at the same time, it does have a redistributive angle to it, which is really the poverty part. So the poorer you are, the more money you get. So in those two fronts, we've made some steps, but then there is still a challenge, because when you think about population and poverty, we don't give any direct money to those things. You give money for health depending on how sick the population is. So if you have two counties with the same population, but one population is sicker than the other one, then it's really not fair to give an equal amount to both counties. So there is still a challenge in that the parameters that we are currently using are really based on proxies of need rather than the direct need that exists in these places. And so going forward, as we get into 2018 and we are thinking of revising this formula, because we have to revise it, then it will be an opportunity for CRA to try and bring in a couple of direct measures of these needs, because it means counties will be better placed to meet those needs when they are getting money that is measured according to what they have to provide.
And so, as a commission, when we came on board in the year 2011, we came up with a policy, and by 2013, we had done a policy. And in this policy, we identified areas that are marginalized. And we used a county as the unit of analysis. One, because of data. We didn't have enough data to go to lower areas. Two, that time, there was this hype about devolution, and everything was county-based. So we were carried by that weight. And so we used county as our unit of analysis. And we identified 14 counties, and they're listed there. Turkana being one of them, Mandera, Wajir, Marsabit, Samburu, West Pokot, Tana River, Narok, Kwale, Garissa, Kilifi, Taita Taveta, Isiolo, and Lamu counties. And this we did using a lot of various approaches, as I will explain later. Now, this policy has been in use for the last 3 years, 2014, 15, and 16, to share revenue from the Equalization Fund. Remember, the role of the commission is only to come up with a policy. Somebody else shares the policy, shares the revenues, and gives the money to these areas. And this somebody else is the national government. So we do a policy, we come up with a criteria, then hands over the criteria to the government to implement.
And then there's something that Marakwet County, for instance, is doing, which most of these other counties in the far-flung areas are also doing, which has really helped us with equity in terms of distribution of services. Doctors traditionally wanted to be near Nairobi or near big towns, Kisumu, Mombasa. In these areas, when you're a specialist, apart from working in the government, you can also set up your clinic and run it. And so there was no motivation for a doctor to want to stay in Marakwet or for a doctor to want to work in Marsabit. But then some county governments, interestingly, in the pay packs for doctors, which is not announced, is that they offer you like a return ticket for two in a month, like to and fro from the city. So they lure people to go and work there with the promise that at least every month you have a return ticket to the capital city. And so that alone is something that is interesting people who have families, because at times, you know, you've already established your family here and someone is sending you to Wajir and you think about it, you say, let me go into private practice, okay, or you may as well just quit government. But now doctors have the incentives, and some counties pay allowances for people to work in those areas under the category of hardship allowances. So that is something that is really a plus.
However, large inequalities also exist within counties, and there are unique interventions being made by individual counties to address them. There have been challenges to these various mechanisms implemented by both the CRA and the county governments, and with lessons learned, different strategies are being drawn as to how to address these challenges.
When we look at the research that was done on infrastructure, we see that actually what was being done before is still being done, okay? So we are spending more, for example, in Nairobi and Kiambu and such counties on infrastructure, and that is the national government.
Now in 2016-2017, in the national budget, the government, for some good reason, decided that they were going to present the development budget, not so much in terms of the monies for development going to the departments within ministries, but they decided that they were actually going to list each individual project under the departments and ministries at the national level. Of course, it's quite a huge number of projects, but we decided to focus on the State Department for Infrastructure and the State Department for Water Services. For roads, and let me start with roads at the top, for the scenarios where we could tell where a project was to be in terms of counties, this is the spread you see in terms of allocations. As you can see, the top 10 has what I would call the usual culprits. Nairobi is at the top. Of all the 47 counties and the allocation made to those projects, 22 or basically 23% of that allocation is for the county that you guys are in, which is Nairobi. Then followed by Mombasa with about 16%. So you can see just those two counties take almost half of the budget, okay? So that's something interesting to note. Now, if you look at the bottom, Vihiga, Lamu, and the rest, they're almost getting nothing. So you can see there are 8 counties actually that had 0. So ideally, you can see that 73 or basically 74% of the budget was allocated to just the top 10 counties. So 37 counties shared a quarter of the budget.
When you go to our wards, you will realize that we usually conduct something called public participation, where these people from the same ward come to one place and they discuss how they share their resources between themselves. We have realized one very serious issue, whereby when you are the host, for example, a sub-location is the host of the public participation process, you end up finding that sublocation getting quite a huge chunk of the money going to that sublocation because majority of the people who participated come from the same location, that place.
So what's the relationship between PB and Makueni's health sector? Since PB comes in at the planning level of the county budget cycle in Makueni, basically through PB, citizens' inputs are collected, then they're incorporated in the budget proposal document, which is then tabled in the county assembly, then it's appraised and approved. Through PB, Makueni has been able to invest in about 53 dispensaries, medical facilities through the PB process. This brings up to a total of about 169 dispensaries. And what Makueni has effectively done in this process is reduce the distance, the average distance to a medical facility from 10 kilometers before PB and devolution to about 4.5 kilometers after PB and devolution. Much as this is the case, you find that many of these facilities, most of which are dispensaries, only have only offer limited healthcare services should a citizen want to go to visit them. And they've also been described as operating at bare minimum. This is information coming from the Ministry of Health at Makueni sub-county.
So generally, and from the sample of counties that we got, it seems like devolution is definitely a good thing because it's given counties or it has given the country some space to discuss what we need in terms of health services within smaller units. And it seems the agreement in many of those smaller units is that we need to increase the number of health staff that we need. Of course, with time, we'll need to measure what kind of impact that has on actual service provision. And that's where things get very interesting because increasing the number of health facilities, increasing the number of health workers does not automatically translate. So that's something that we have to actually see whether it will play out, because it could be that we are just building health facilities, but they are not running. It could be that we are employing people and they are all in Lodwar, not in Loima or in Kibich or elsewhere in Turkana County. So there is still some more work to do to understand how this plays out.
And then the last thing, which is what also Caleb said, is the need to consider within county distribution, how is the inequality within the county. And we're seeing counties like Turkana, we're looking at their data, and they're projecting to increase their health workers by a certain percentage, but the distribution of health workers in different sub-counties and different hospitals, it's responding to some inequalities, okay? So beyond the across the country inequalities, there's still inequalities within the county that we need to consider in distribution of health human resource.
And of importance to us, I think, is the formula which CRA is using. And we've been critically looking at this formula, and we realized that this is a formula which I'm told it was borrowed from South Africa, which compared to Kenya, they've already developed their infrastructure. For example, when we come to issues like roads, a county like Elgeyo Marakwet, we are still struggling to start new roads. And using the formula to, the formula mainly focuses on maintenance of roads which are already existing, and even water projects and other projects. And of great importance to, I think, most of the counties who are present today, because you realize that agriculture is the main economic activity in our counties. And I've been trying to look at the CRA formula to see where agriculture comes out clearly. And you realize that maybe a county like Nairobi, which has the highest population, will get more money which were meant for agriculture, and Elgeyo Marakwet or maybe Makueni will receive less money which were meant for maybe irrigation and agriculture. So I think as we discuss this, we also need to look for ways of engaging the CRA and even the National Assembly and Senate, so that as we move to the next phase of, or we amend the formula, some factors are considered that will bring equity to all our counties.
That first policy was operational for only 3 years. and the 3 years have passed. And so the Commission is in the process of coming up with another policy. We call it the second policy, identifying marginalized areas. We want to go lower, as he said. We no longer want to use the county as our unit of analysis. This is just to improve targeting, because at times, there are counties that people think are doing so well, the Kiambus, the Kajiados, the Nairobi, and yet there are pockets of marginalization in such counties. These are the people we want to target. And it's partial, like we identify areas, not communities.
When 2013, when we did the Commission of Revenue Allocation as a country, they did it without doing costing of functions. And eventually they gave us a formula, which I can say here that is disadvantageous to majority of the counties, and Elgeyo Marakwet being one of the leading in terms of being disadvantaged. So when they did that one, they didn't look at so many parameters. And I think even when we are discussing today, we should look at those parameters. When you only say you want to use population, you want to use area. In Elgeyo Marakwet, we have a serious challenge in terms of terrain. Terrain is a serious issue. We might be the same area square kilometers. We have the same area square kilometers, but Elgeyo Marakwet and a county like Uasin Gishu, a county like Baringo, a county like Nandi, we have unique features. So for Elgeyo Marakwet to do a kilometer of a road in Elgeyo Marakwet probably can cost 10 times more than a road in Uasin Gishu or a road in another county. Same to our brothers in Baringo.
And then there's this issue on recurrent and development share. We realized as we were looking at the budgets from these counties, for example, Samburu and Elgeyo Marakwet and Busia and so many counties, that they're struggling to keep within the 70-30 rule. What the PFM Acts provide is that you should not surpass recurrent expenditure of 70%. And most counties at 69%. Some counties are even at 72% when you look at their budgets. And what it means to get more health workers is recurrent expenditure, isn't it? So what the trend has been, for example, in Samburu, in 2014, 15, and then 16, 17, they've been spending on infrastructural projects, which means health facilities, right? So now they have all these health facilities. They've gotten dialysis equipment. They've been spending on capital expenditure. So now they are in a situation where they need to fill those places with workers, right? And what does it mean? It means you spend on recurrent, but there's this legal requirement of 70-30. What do they do to get more health workers into their country? So that's an issue that we've seen in many counties, that even if they want to recruit health workers, they're still limited by this legal provision.